Let's take a look at the revision of surgical trauma. Now, here in surgical trauma, first of all, we'll be talking about how we need to save the life of any trauma patient. And then, if we look at the organ specific areas, head, face, neck, chest, abdomen, limb traumas, then facial trauma is something which is covered in our ENT, neck, cervical spine, orthopedics, limb, orthopedics. So we are left with the head, chest, and the abdomen trauma. First of all, let us see how a polytrauma patient has to be saved. Suppose, let us imagine any disaster type of situation, then National Disaster Management Authority has laid down some guidelines wherein as soon as you receive the information of disaster in the emergency, you have to immediately send quick response teams to the disaster site. And these QRTs or quick response teams, they comprise of paramedical staff. Their job is to provide the first aid. If there is any active bleeding, they have to put the tourniquet. Any fracture, they have to stabilize that area. Any mud, debris, dirt in the mouth or the nose, they have to clean that so that the airway can be clean, and they have to immediately transfer these patients to the hospital. In the hospital, you doctors have to carry out a emergency severity index, wherein your aim is to save the life of the patient. That means you have to supply oxygen to the vital organs as early as possible. That will save the life of your patients. Right. And at every stage, we keep on doing the trial, we keep on segregating the patients into different categories: red, yellow, green, black. Now, in these situations, first we have to save the life of the patient. So, primary assessment, that is, how the oxygen will be going into the vital organs. We know there are airways through which oxygen is going inside. Then there are air balloons, lungs, which are expanding. So the oxygen is going into the alveoli. And then from the alveolar membrane, this oxygen is diffusing into the blood, the pipeline, which is distributed throughout the body. So we have to restore these airways, breathing, and the circulation stories. So in the primary assessment, the ABC of life: A for airway, B for breathing, C for circulation, and we also assess the disability and take care of the exposure part as well. Once we'll be able to supply oxygen to the vital organs and the life of the patient is saved, then we will have sufficient time where we can do a secondary survey where a detailed history, detailed clinical examination, special investigations, and the definitive treatment can be done. If we look at the airway story, then if suppose in a trauma patient we find that the airways are getting blocked, first of all we have to clean up the airways, the mouth, the nose area, so that oxygen can go inside. Then to secure the airway, we have the option of putting a laryngeal mask airway from the mouth, or we can do a endotracheal intubation from the mouth or the nose. Nasal intubation is contraindicated in anterior cranial fossa fractures. If by chance we cannot access the airway from the mouth or the nose, like in maxillofacial trauma cases, or there may be huge amount of edema in this mouth-nose area, then we secure the lower airways. If we have got time, that means patient is not immediately dying, then we can do a tracheostomy. But if it is a sudden story and patient is dying very quickly, then we don't have time to do a tracheostomy. We can simply do a needle cricothyroidotomy. Needle cricothyroidotomy, generally we use a wide bore needle, of 14 gauge needle, or we can simply do a cricothyroidotomy as well. So these are the methods to secure the airways. Once the oxygen is going through the airways, then we have to see whether the lungs are able to expand or not. There might be situations in chest traumas where there may be collection of something in the pleural cavity, maybe air like pneumothorax, or maybe blood like hemothorax, or maybe a combination of both, hemopneumothorax, which may be putting pressure on the ipsilateral lung, because of which that side lung is not being used by the person. So if only one lung is under pressure, other lung is normal, then this patient is not going to die quickly, because oxygen is going to the other lung, and from the other lung it will be going into the pipeline. So oxygen will be going to the vital organs. That means we have got sufficient time in these patients. They will be presenting with difficulty in breathing though, because one lung is under pressure, but because we have time, So in these cases, we have to put a tube in the pleural cavity, that is tube thoracostomy or intercostal tube drainage, drain all the collection and advise breathing exercises so that the lung can expand. If by chance there is huge amount of collection in the pleural cavity, like massive air collection in the pleural cavity, which is not only putting pressure on the ipsilateral lung, but it is also causing mediastinal shift so that the other lung is also under pressure. Now, if both the lungs are collapsed, then oxygen is not going into the pipeline, oxygen is not going to the vital organs, and this patient will die very quickly. We do not have the time to put the tube, but at least we can do a needle decompression. So a wide bore needle has to be used to decompress, which can remove some air from inside and cause some decompression so that some amount of oxygen can go into the lung and some amount of oxygen is going into the pipeline. At least we can get some 10, 15, 20 minutes, and these 20 minutes would be sufficient to put a tube into the thorax, and then we drain all the collection from the pleural cavity, advise breathing exercises and achieve adequate lung expansion. So remember, if only single lung is under pressure, patient is not dying, you can put the tube. But if both the lungs are under pressure, patient is dying, first put the needle and then decompress and then put the tube. Sometimes in burn patients, there might be paralysis of the respiratory muscles because of which the lungs are not able to expand. Put the patient on artificial lung machine or ventilator and achieve adequate lung expansion. That is how, when you restore the breathing, oxygen is going down into the alveoli, and at the alveolar membrane it is diffusing into the pipeline. Now you have to see whether there is sufficient pressure in the pipeline or not. In trauma situations, if there is bleeding going on, there is loss of volume in the pipeline, loss of pressure in the pipeline, because of which oxygen is not going to the vital organs. So you have to generate the pressure in the pipeline. You have to pump in IV fluids. Generally, whenever there is hypovolemia type of story, the compensatory mechanisms in the body, they start, like heart start pumping faster and faster, tachycardia, so that oxygen can be supplied. The vessels in those areas of the body which are not vital for life, like skin, GIT, muscles, vessels in those areas will constrict and will divert their blood towards the vital organs so that the patient can survive cutaneous vasoconstriction. However, if huge amount of fluid has been lost, then definitely pressure in the pipeline will be going down and these compensatory mechanisms will not be sufficient. So in all hypovolemia situations, the earliest sign what we see is tachycardia. Cutaneous vasoconstriction is an early sign, but hypotension is a late sign of hypovolemia, which occurs when more than 30% of volume has been lost. To restore that volume or to generate pressure in the pipeline, we have to give IV fluids. We prefer using crystalloids and not colloids, especially till the time when the vessels are leaky. If suppose there is a leak in the pipeline, whether you are giving crystalloid or colloid, both will be going into the pipeline, both will be leaking out from that leak area in the from the pipeline. If colloid come in the extravascular space, they will exert their oncotic pressure and will drag more intravascular volume into the extravascular space, further aggravating hypovolemia. So we prefer giving crystalloids like normal saline or maybe ringalactate or maybe Hartmann solution, which is very close to the ringalactate. Colloid solutions which have got proteins like albumin solution, even our blood is having plasma proteins, so blood is also a colloid solution. Now, when we have to pump in crystalloids, generally we prefer using normal saline, but in those situations where there is metabolic acidosis, like in burn patients, so there we prefer using ringalactate. When we have to pump in this normal saline, we put two wide bore cannulas, because if one cannula gets blocked, then at least the other cannula is patent. And generally a wide bore IV cannula is used in these situations. And in this, to remember the color coding of the IV cannulas, there is a mnemonic. If we look at the core of the earth, Mother Earth, volcanic eruptions we have seen, orange color. Surface of the earth, the roads, they are gray. On the surface of the earth, there is a green grass, there is pinky flower, blue sky, yellow sun, and in rainy weather, vibgyor, violet, orange, gray, green, pink, blue, yellow, violet, orange, gray, green, pink, blue, yellow, violet. 14, 16, 18, 20, 22, 24, 26. If the gauge is less, that means the bore, the diameter is more. So 14, 16 gauge are used in shock patient where you have to give a huge amount of fluid in quick time. Like 1 liter of normal saline is generally used as fluid challenge, which is given within 1 hour. Green can be used in shock situations, but more often it is used in adult males in normal scenarios. Pink is the color of females, so in normal scenarios in females we use pink. In children, blue, that is 22 gauge. In infants, yellow, that is 24 gauge. And in newborn baby, neonate, we use violet, that is 26 gauge. Whatever fluid you are giving in the pipeline, if you are able to generate sufficient pressure in the pipeline, then sufficient fluid will be going to the kidneys and the urine output will be normal. The minimum urine output which we consider in an adult, we take it that it should be more than 0.5 ml per kg per hour. In children, it should be more than 1 ml per kg per hour. And in infant, it should be more than 2 ml per kg per hour. Though in adult, we take it as 0.5 to 1 ml per kg per hour as the normal urine output, which we try to restore. But at least it should be more than 0.5 ml per kg per hour. If suppose, despite pumping in IV fluids, you are not able to generate sufficient pressure, that means sufficient fluid is not going into the kidney, so urine output will be less. In these cases, urine output will be a nice guide to monitor fluid resuscitation. If the output is less, you have to give more amount of fluid. If there is more than 30% of blood loss in trauma situations, then just by giving IV fluid, just by giving normal saline, this is not going to help, because patient has lost more than 30% of RBCs, platelets, clotting factors. That means more than 30% of hemoglobin is gone. Hemoglobin is less in the pipeline. Agreed that by normal saline you are increasing pressure in the pipeline, but if there is less hemoglobin in the pipeline, then who is going to carry oxygen to the vital organs? So you have to give RBCs for hemoglobin so that they can carry oxygen to the vital organs. We know that in these situations we need to stop the bleed, so we need platelets and clotting factors as well. That means more than 30% of blood loss situations, we need to give RBC, platelets, clotting factors. We don't need WBC, so we prefer giving leukodepleted blood transfusions. Tranexamic acid injection has to be given, which can help in attracting the platelets and clotting factors and stop the bleeding. If by giving normal saline, blood transfusion and tranexamic acid, whose first dose should be given within 10 minutes, preferably within 3 hours, second dose to be repeated within 8 hours. If by giving this normal saline, blood transfusion and tranexamic acid, you are able to generate sufficient pressure in the pipeline and sufficient oxygen is going to the vital organs, wonderful. If despite pumping in normal saline blood Trenexa, you feel that pressure in the pipeline is not coming up, it simply indicates that there is major leak inside the body. Whatever you are giving, that is leaking out. So pressure in the pipeline is not coming up, oxygen to the vital organs is not going, patient can die very quickly. You are the second God, you cannot allow this to happen. Don't wait for anything. Immediately open the area where you suspect the bleed and apply direct pressure. The best method to control bleeding is direct pressure. Now you ask your assistant to pump in IV fluids and blood. This will generate pressure in the pipeline and will supply oxygen to the vital organs. How to assess whether the patient is hemodynamically stable or unstable? Though there are various parameters, but what we can use very simply is heart rate and systolic blood pressure. This ratio is shock index. If the shock index is less than 1, then patient is stable. But if the shock index is 1 or more than 1, then patient is unstable. To assess the disability, we can check for the Glasgow Coma Scale. That is, if suppose sufficient oxygen is not going to the vital organs like brain, the brain responses will be altered. To see that, we can measure a Glasgow Coma Scale where we assess eye, verbal and motor responses. Maximum eye score possible is 4, verbal 5, motor 6. Minimum is 1, 1, 1. So total maximum GCS possible is 15 and total minimum GCS possible is 3. Now, we can even classify whether it is mild, moderate or severe. 13 to 15 is mild, 9 to 12 is moderate and 8 or less than 8 is severe. So, you just remember 9 से 12, चलती क्या 9 से 12, 9 to 12, that is moderate. How to assess this Glasgow Coma scale? How to assess this Glasgow Coma scale? If the patient is able to open his eyes spontaneously, you give him I4. If his eyes are closed, you give him a voice command or sound command. Aankh kholiye, if he opens his eyes to voice command, that is I3. If he does not open his eyes to voice command, give him a painful pressure stimulus. If he opens his eyes on painful pressure stimulus, this is I2. And if he does not open his eyes even on painful pressure stimulus, this is I1. Verbal responses. If sufficient oxygen is going to the brain, his verbal responses would be normal. He may be fully conscious, oriented to time, place and person. Verbal 5. If he is confused, verbal 4. If we start using inappropriate words, abusive language, that is verbal 3. And if he is not able to speak out any words, but he's just making some sounds, this is verbal 2. And if he's not able to make any sound also, this is verbal 1. Motor responses, muscle movements. If he is obeying your commands, this is motor 6. If he is not obeying the commands but he is able to localize, this is motor 5. If suppose on pinchy stimulus, he is not even localizing but he is trying to withdraw normal flexion, this is motor 4. Abnormal flexion, motor 3. Extension, motor 2. And no movement, motor 1. Out of these, motor response is considered good for prognosis. Sometimes we may not be able to calculate these responses. For example, if you have put the endotracheal tube through the vocal cords, he will not be able to speak. So verbal response cannot be assessed. There we use the term NT, non-testable. Sometimes there may be a variable response on two sides. Suppose you ask the person to raise his right upper limb. He raises the right upper limb. That means he is obeying the commands. But if you ask him to raise the left upper limb and he does not raise the left upper limb, that means it is not motor 6 on the left side. There is a variation between right left side. In such cases, better response is considered in GCS. E is exposure, where you have to expose the patient completely. You have to remove all the clothes of the patient, but please take care. In all those situations where there is hypovolemia, whether it is vomiting, diarrhea or bleeding, then it is not only the volume which is getting lost from the body, heat is also getting lost from the body and patient is going into hypothermia. So whenever you are exposing the patient, please do cover the patient with warm blankets, and whatever IV fluids you are giving, they should not be cold, they should be warm IV fluids. Otherwise, patient can die of hypothermia. At every step we are doing the triage, we are segregating the patient into different categories: red, yellow, green, black. If injury is immediately life-threatening and will require immediate intervention, it is red. If injury is not immediately life-threatening, patient is stable but will require early intervention, then it is yellow. And if it is an ambulatory patient, no life-threatening story, then it is green. And if the patient is moribund or patient has died, then it is black. White is an ambulatory patient who does not require any type of hospital care. Once we have done this airway, breathing, circulation, disability, exposure story, we are able to supply oxygen to the vital organs. Life of the patient is saved. Now we have got sufficient time. We do secondary survey. When we take the detailed history, we should not forget about ample, A for allergy, M for medications, P for past illness, pregnancy, L for last meal, and E for events of injury. If this trauma patient was taking some medicines, which increases the risk of bleeding, like aspirin or maybe warfarin or heparin, then we have to immediately stop these medicines, and we might need to give counter medicines. Like if patient was taking aspirin, we should give platelets. If patient was taking warfarin, we should give vitamin K and fresh frozen plasma. If patient was taking heparin, we should give protamine sulfate. We need to do a head-to-toe detailed examination. Special investigations like X-ray, CT, contrast studies, endoscopies can be done, and then definitive treatment can be done. Shock. Shock simply means hypoperfusion of tissues. That means inadequate organ perfusion and tissue oxygenation. Less oxygen supplied to the tissues. Depending on who is the culprit, if heart is not pumping, suppose myocardial infarction, direct trauma to the heart is not contracting, cardiogenic shock. If there is a leak in the pipeline, hemorrhagic or hypovolemic shock. If suppose there is any sepsis type of thing, some infection or acute inflammation in an area, there might be vasodilatation so that more blood is coming towards the inflamed organ. That means blood is getting diverted from some other areas. Blood is getting redistributed inside the body. This is distributive shock. In neurogenic shock also, when there is a blockade of the sympathetic flow, sympathetic outflow gets blocked, then also there may be pooling of blood in the capacitance veins. So veins will be having more amount of blood. There is distribution of the blood, redistribution of the blood. This is a distributive type of shock. Obstructive shock. If suppose there is someone who is pressing the vena cavas so that blood is not going into the heart, like intention pneumothorax stories or maybe cardiac tamponade stories. Cardiac tamponade, when there is huge amount of blood getting collected around the heart, this may cause compression of the vena cavas, so blood is not going into the heart. How will the heart be able to pump this oxygen out? This is obstructive shock. And if this is because of hormone, maybe sudden release of thyroid hormones, that is an endocrine shock. Most common in trauma situation is the hypovolemic shock, and the earliest sign of hypovolemia is tachycardia. Cutaneous vasoconstriction is an early sign. Hypotension is a late sign of hypovolemia. Hemorrhage and blood transfusions, if we see how to measure the amount of blood loss. Blood loss in a fist is taken as 500 ml. Blood loss in closed fractures like tibia humerus fractures is 750, femur 1500, and pelvic fractures 2000 to 2500 ml. We can segregate the blood loss into 4 categories, just like the scores in a lawn tennis game: 0 to 15, 15 to 30, 30 to 40, more than 40. That means 0 to 750, 750 to 1500, 1500 to 2000, and more than 2000 ml. We know that systolic blood pressure starts falling when there is more than 30% of blood loss. How the great doctors of this country will come to know which category of blood loss you are dealing with. Class 1 and class 2, 0 to 15 and 15 to 30, systolic pressure is normal. And if pressure in the pipeline is normal, sufficient fluid will be going to the kidneys, urine output will be normal, sufficient oxygen will be going to the brain, Glasgow coma scale will be normal. But more than 30% of blood loss, when pressure in the pipeline starts decreasing, urine output and GCS will also start decreasing. And in class 4, they will markedly decrease. Urine output may almost be negligible in class 4 blood loss. We can assess the pulse rate and the respiratory rate as well. Class 1 blood loss, where the blood loss is just 0 to 15%, less than 750 ml of blood loss, may not affect the parameters. Pulse rate may be less than 100, respiratory rate may be less than 20 per minute. But in class 2 blood loss, pulse rate will rise 100 to 120, class 3 120 to 140, class 4 more than 140. Respiratory rate in class 2 20 to 30, class 3 30 to 40, and class 4 more than 35. The best or the ideal replacement for blood loss is blood transfusion. When we are taking the blood from the donor, it is stored in the refrigerator. Whole blood is stored at 4 plus minus 2 degrees centigrade in the refrigerator. And the anticoagulant commonly used now is sagam, sodium chloride, adenine, glucose, and mannitol. This increases the shelf life of or viability of the cells for 5 weeks. Earlier we were using CPD and CPDA, CPD citrate phosphate dextrose, that had a shelf life of 21 days, CPDA 28 days, sagam 35 days. There can be some complications after blood transfusion, like transfusion reactions can occur, and the commonest reason for this transfusion reaction or mismatched blood transfusion, this is clerical error. By mistake, a wrong blood is transfused. And if a wrong blood is transfused, most common symptom is pain and heat sensation along the vein from where the blood is going. There would be antigen-antibody reaction, which will form large clumps, and these large clumps traveling in the pipeline can block the filter of the body, that is the kidneys. So the urine output will decrease. Most common early sign of mismatched transfusion is oliguria. We can find hemoglobinuria also. While if suppose surgeon is operating a patient and anesthetist gives the wrong blood, surgeon sees generalized oozing of blood from the cut surfaces, which also indicate a mismatched transfusion. The risk in mismatched transfusion is choking of the kidneys. So we do not want those clumps to block the filter. We give diuretics to clear those clumps. If that is not successful and the filter remains choked, then we'll end up in doing dialysis as well. Various infections can be transmitted through blood transfusion like hepatitis B, hepatitis C, HIV, malaria, and syphilis. Sometimes we need to give massive blood transfusion. If we are giving more than 10 units of packed RBCs within 24 hours, or more than 4 units of packed RBCs within few hours or maybe within 1 hour, this is massive transfusion. And in massive transfusion, when we are transfusing the blood very quickly, it can lead to volume overload in the patient, especially in anemics and elderly people, which can lead to congestive cardiac failure. We can find hyperkalemia and hypokalemia in the recipient after massive transfusion. Hyperkalemia is because in the stored blood, the cells are getting lysed, like RBC, WBC, platelets, clotting factors, they are getting lysed. 98% of potassium is intracellular. Due to lysis of cells, the potassium will be released in the bag. So there is more amount of potassium and you are giving massive transfusion. So more amount of potassium is going in the recipient, hyperkalemia. However, the chelating agents which we are using or the anticoagulants, like very commonly seen with citrate if it is used as anticoagulant, this anticoagulant, when it is going in the recipient, it can bind with the recipient ions like potassium, calcium, magnesium, and that can cause hypokalemia, hypocalcemia, hypomagnesemia. Also, in massive transfusions, we will not be getting sufficient time to warm the blood, so there can be hypothermia in the recipient. Because we know that cells are getting lysed in the blood bag, so we may not get viable sufficient platelets and clotting factors. We are giving huge amount of fluid, maybe in the form of blood, but if the viable cells are not there, viable platelets are not there, this will lead to related deficiency of platelets in the recipient, thrombocytopenia. This will lead to related deficiency of clotting factors in the recipient, which can lead to dilutional coagulopathy, disseminated intravascular coagulopathy, DIC. In these cases, we have to give fresh frozen plasma, which is a very rich source of clotting factors. FFP is stored at minus 40 degrees centigrade and it has a shelf life of 2 years. This may help in preventing patient going into DIC. In massive transfusions, the dictum is 1 on 1. 1 unit of blood, 1 unit of fresh frozen plasma. The stored blood has a acidic pH 6.3. Massive transfusion can lead to metabolic acidosis in the recipient. If we look at the organ-specific traumas, like head trauma, scalp, skull, brain. Loose areolar tissue is the most dangerous zone in the scalp because there are emissary veins connecting the scalp with the brain. So scalp wounds should not be taken lightly. They should be irrigated thoroughly with normal saline, and they should be sutured in two layers, the aponeurosis and the skin. Skull fractures can be linear skull fracture, which is seen with blunt trauma to the skull. There is a linear cut on the bone. Depressed fracture is seen with a penetrating trauma, like maybe a hammer injury, and this is going to cause this depressed skull fracture. We can come across base of skull fractures. Base of skull can be divided into anterior, middle, and posterior cranial fossa. Most common part injured in anterior cranial fossa is the cribriform plate in the ethmoid bone. This can lead to CSF rhinorrhea, which is confirmed by beta 2 transfer in the target sign halo sign. We may see brownish discoloration around the eyes, bluish brownish discoloration around the eyes. This is raccoon eyes or panda sign in anterior cranial fossa fractures. Middle cranial fossa fractures, the commonest part injured is the petrous part of temporal bone. There can be CSF autoria, and we can find this Bettel sign. This is bruising or brownish discoloration at the mastoid, commonly seen in middle cranial fossa fractures, but can be seen in posterior cranial fossa fractures also. Pons fracture commonly seen in children, like a dent on the ping pong ball. Orbital blowout fractures, most commonly it is the floor of the orbit. Second most commonly it is the medial wall of the orbit. Brain injuries, we know that CSF and skull, they both protect the brain. There can be coup injuries, counter coup injuries. Coup is injury at the site of impact. Counter coup is injury remote from the site of impact. There can be different hematomas like intracerebral, extradural, subdural, subarachnoid. There may be cerebral herniation. If blue color here is the dura mater, depending on where the blood is getting collected, if it is getting collected outside the dura below the periosteum, it is extradural. Below the dura mater, subdural. Within the brain parenchyma, intracerebral. Extradural or epidural, this is commonly seen at the temporoparietal region. Pterion, middle meningeal artery, which is a branch of maxillary artery, is commonly injured. However, transverse sagittal sinuses can be injured. Out of these different hematomas, extradural is farthest from the brain parenchyma. So it may take some time to put pressure on the brain parenchyma. And this transient period of consciousness after trauma, when the patient remains fully conscious and can carry out normal routine activities, this is lucid interval. Subdural hematoma, also called as the Box's hematoma, commonly seen in the frontoparietal region, due to injury to cortical bridging emissary veins, can be classified as acute, subacute, and chronic. First 3 days acute, 4 to 21 days subacute, and more than 21 days chronic. When we do a CT scan, then extradural hematoma, it appears hyperdense biconvex. The spelling of extra has a X and convex also has a X. This what we are seeing is a bilateral convex, biconvex. So it's a bilateral extradural hematoma. However, in subdural hematoma, it appears hyperdense concavo-convex or convexo-concave. So, just Right. This is a very commonly asked MCQ here, the hyperdense biconvex, and here it is hyperdense concavo-convex. Now, whether it is extradural, subdural, or maybe intracerebral, the issue is these hematomas are going to increase pressure inside, so intracranial pressure will increase. This will compress the cerebral blood vessels which are supplying oxygen to the brain parenchyma, so that proper oxygen is not going to the brain parenchyma. More the duration of hypoxia to the brain parenchyma, more will be the chances of irreversible damage to that portion of the brain parenchyma. That is why we want that oxygen supply to the brain parenchyma should be restored as early as possible. That is why in the management of head injury, we aim at reducing the intracranial pressure so that we can increase the cerebral perfusion pressure. Normally, intracranial pressure is between 8 to 12 millimeter of mercury. We take it as 10, but if it is more than 22, it is fatal or dangerous. Our aim is to keep the intracranial pressure less than 20 millimeter of mercury. Cerebral perfusion pressure. This is mean arterial pressure minus the intracranial pressure, and we try to increase the cerebral perfusion pressure above 60 millimeter of mercury. To reduce the intracranial pressure, we can use some diuretics. We can use mannitol. Mannitol is the osmotic diuretic of choice in brain edemas. Osmotic diuretic of choice in brain edemas. Mannitol should be used with caution in large intracranial bleeds, because mannitol can cross the blood-brain barrier, and if it goes into the bleed area, it can create that osmotic gradient and it can increase the size of bleed. However, a better option to reduce the intracranial pressure would be creating the burr holes, or maybe doing a decompressive craniotomy and evacuate the hematoma. Decompressive craniotomy would be the best. Lumbar puncture as far as possible is best avoided. Fluid management is not that important in head injury because brain is surrounded by the skull. So even if it is a huge amount of bleeding in the brain, it is not going to be as huge as it can cause hypovolemia or shock. If we have to give fluid in head injury patient, we can give normal saline, we can give ring lactate, hypertonic saline, but glucose dextrose based solutions should be avoided as hyperglycemia is harmful to the brain, because glucose because of its osmotic action will drag fluid from the brain cells outside and will make the brain cells dehydrated and may lead to hypoxic injury or maybe injury to the brain cells. So hyperglycemia should be avoided. If we look at the chest traumas, then most commonly injured would be the ribs. Generally 4 to 9 ribs on the left side are more commonly injured, and this can lead to a pneumothorax, hemothorax, hemopneumothorax. Sometimes tension pneumothorax can occur in chest traumas. A sucking wound of the chest or open pneumothorax can be seen. Flail chest can be seen. All the lovely doctors, we do understand that suppose there is a rib fracture and this rib fracture has caused injury to the pleura of the lungs, because of which air has started getting collected in the pleural cavity. And if it is putting pressure on the ipsilateral lung, as we can see here, this ipsilateral lung is collapsed. But the other lung is normal, so oxygen can go to the other lung and then it will be going into the pipeline. So this patient is not going to die. Patient will be presenting with mild difficulty in breathing or dyspnea. This is a case of hemothorax, suppose. Here also we are seeing that only one lung is under pressure. So oxygen is nicely going here into the pipeline. In these cases, when patient is not dying, we can do the clinical examination. In clinical examination, percussion and auscultation very important. Percussion is done with the middle finger on the middle finger, and the movement in percussion occurs at the wrist joint. While Auscultation. Obviously, here we can find normal breath sounds, but here we will not find the breath sounds. So breath sounds may be diminished or absent, and that will give us an idea about the lung collapse. To see this, we can take a chest x-ray. In chest x-ray, air appears black. So if you find more blackness, hyperlucency, then this will be a case of pneumothorax. You can have an argument that this is normal and this is less black. Whenever you get confused, try to look for the bronchovascular markings, which are the impressions of the blood vessels on the surface of the lung. Here you can see the bronchovascular markings, but here you cannot see the bronchovascular markings. That means here the lung is present, here the lung is not present. So this is a case of left-sided pneumothorax. When we talk about any hydrothorax or hemothorax story, the fluid or blood will settle at the bases and fluid appears white on X-ray. So you see white haziness on X-ray here, plus there is a blunting of the costophrenic angle. Here the costophrenic angle is quite sharp, but because of fluid accumulation or blood accumulation, this angle has blunted here. So we can get some idea on chest X-ray. If there is any doubt, we can do a CT scan also. In the treatment, what we want to achieve, we want that this lung should expand. This is what we want to achieve. To do this, we should put the intercostal tube drain in the 4th or 5th intercostal space, just anterior to the mid-axillary line, along the upper border of the lower rib. Generally 28 to 32 French catheter is used. We cannot leave the outer end of the tube exposed in the atmosphere because outside pressure is positive and inside pressure is negative. If we just leave the outer end of the tube like that, the outside air will go inside. So the outer end of the tube has to be dipped in a water column. We use a special type of underwater seal bag where we fill 100 ml of normal saline in this bag, and the outer end of the tube is dipped in the water column inside so that outside air does not go inside. Now, when we are doing this, once the collection has been drained, then we have to advise breathing exercises to the patient so that the lung can expand. We can give spirometer, we can give football bladder to the patient for lung expansion. Intercostal tube drain is put in the 4th, 5th intercostal space, just anterior to the mid-ax line in the triangle of safety along the upper border of the lower rib, and it is connected to underwater seal bag. Sometimes there is a possibility as soon as you put the intercostal tube, suppose huge amount of blood is coming out, more than 1.5 liter or more than 1500 ml of blood is coming out from the tube within 1 hour, that is more than 20 ml per kg in 1 hour, or maybe more than 200 ml per hour consecutively for more than 2 to 4 hours, that is more than 3 ml per kg per hour. That means a significant bleeder is bleeding inside, and now you cannot wait for this bleed to keep on occurring. You have to immediately do a thoracotomy, apply direct pressure and control the bleed and save the life of this patient. So this is the indication of thoracotomy. More than 1500 ml of blood coming out from the tube within 1 hour, or more than 200 ml per hour consecutively for more than 2 to 4 hours. Even in major tracheobronchial esophageal ruptures, we have to do a thoracotomy. Tension pneumothorax is a different type of story. Suppose there is massive air collection in the pleural cavity, which is not only causing ipsilateral lung collapse, but it is also causing mediastinal shift, which is putting pressure on the other lung. Both the lungs are getting collapsed, patient will die very quickly. In these scenarios, we find that the vena cavas are also compressed. So suppose superior vena cava is compressed, then this blood will get pooled in the neck and the facial veins, which get engorged, dilated. Jugular venous pressure will be high. Because blood is not coming into the heart properly, so heart will not be able to generate sufficient pressure in the pipeline. There will be hypotension. In tension pneumothorax, heart sounds will be normal, but breath sounds will be diminished or absent. In cardiac tamponade, when there is suppose heart injury and blood gets collected around the heart, in those cases also, the vena cava will be compressed, the neck facial veins will be dilated and JVP will be high, because less blood is going into the heart and heart is not able to contract also, so heart will not be able to generate pressure in the pipeline, hypotension will be there. But in cardiac tamponade, Because of blood around the heart, heart sounds will be muffled, breath sounds will be normal. So heart sounds, breath sounds. Heart sounds will go down in cardiac tamponade. Breath sounds will go down in tension pneumothorax. In cardiac tamponade, this raised JVP, hypotension, and muffled heart sounds is called as back striate. For tension pneumothorax, when both the lungs were under pressure, we were not having the time to put the tube, but we have to put a wide bore needle in the 4th, 5th intercostal space just anterior to the mid-axial line, or we can put it in 2nd intercostal space in mid-clavicular line, which is usually done in case of children. That wide bore needle will cause decompression. We will save the life of the patient maybe for some time, and then we can put the tube and advise breathing exercises. In cardiac tamponade, earlier we were doing needle pericardiocentesis, but now that is not done. We should do immediate thoracotomy and take control of the bleeding from the heart. Right. There is a sucking wound of the chest, that is open pneumothorax. Suppose somebody hits a knife in the chest, takes the knife out. If the size of the wound is more than 3 centimeter, then outside air will go into the pleural cavity. So it's a communicating wound between the pleural cavity and the outside atmosphere. If the size is more than 3 centimeters, outside air goes inside and can lead to huge amount of air collection inside. Immediately what we can do is we can just take a silver foil or maybe any covering and do a taping on 3 sides. By doing so, the outside air will not be going in, but inside air will be coming out. So this will be acting as a valvular dressing. And then we can do intercostal tube drainage and breathing exercises. Flail chest is 3 or more than 3 consecutive rib fractures at 2 or more than 2 sites, like 3 or more than 3 consecutive rib fractures at 2 or maybe more than 2 sites. This is flail segment and it shows paradoxical respiration, that means opposite movement. During inspiration, generally what happens, the lungs are moving out, ribs are moving out, but in flail chest, during inspiration, lungs are moving out and this flail segment is moving in, which can lead to serious lung injury. So this is a dire surgical emergency where we can give intermittent positive pressure ventilation so that when the lung is moving out, the rib flail segment is also moving out. However, immediate surgery will be required. Gold standard investigation in trauma situations is a CT scan. The various emergency conditions in chest trauma like tension pneumothorax, open pneumothorax or sucking wound of the chest, flail chest and cardiac tamponade. If we look at the abdominal trauma, blunt abdominal trauma most commonly spleen, second liver. Penetrating abdominal trauma most commonly liver, second small intestine. Seat belt abdominal trauma or whiplash injury most commonly mesentery and the intestines. Mesenteric injury, because mesentery is having intestinal blood vessels, so it can cause gut ischemia. Intestinal ruptures can occur. Bomb blast explosion, huge amount of energy is released under pressure upwards, so air-filled cavities from top to bottom are injured in sequence. Tympanic membrane of the eardrum, trachea, lungs and the intestine. In blunt abdominal traumas, suppose a car has run over the abdomen of a person who was crossing the road. There can be significant injury to the spleen, liver, which can lead to massive bleeding, volume in the pipeline going down, pressure in the pipeline going down, oxygen supply to the vital organs going down. This patient can die very quickly. Immediately, you have to wheel this patient in the hospital, transfer this patient quickly to the hospital, and in the emergency, we have to focus on saving the life of this patient. Basic resuscitation, A, B, C, D, E, airway, breathing, circulation. Now, when this basic resuscitation is going on, they are trying to supply oxygen to the vital organs. If you have the facility of this E-fast, then you can do E-fast in these patients, which will give a quick idea what is the source of bleeding in this patient. Like original fast, focused assessment by sonography in trauma, epigastrium for pericardium, right hypochondrium for liver and right kidney, left hypochondrium for spleen and left kidney, and pelvis for any free fluid in the peritoneal cavity. Now it has been extended to the thorax where bilateral pleural cavities are also evaluated. So we call it as extended fast or EFAST. When all this resuscitation is going on, if despite pumping in IV fluids, blood, Trenexa, the pressure in the pipeline is not coming out, it means there is a major leak inside and we should not wait. We should open the abdomen quickly in the operation theater by a midline incision. This is the fastest access, plus equal exposure can be there on both the sides. And sometimes in major liver bleeds, we are not able to control those liver bleeds. We are not able to identify from where it is bleeding. We can simply put our thumb and index finger in the foramen of Winslow, or maybe clamp in the foramen of Winslow in the hepatoduodenal ligament, where there is portal vein and the hepatic artery. 80% of blood to liver is supplied by the portal vein, 20% by the hepatic artery. If you clamp both of them, no supply to the liver and major liver bleed will stop. Now pump in IV fluid, blood, Trenexa, generate pressure in the pipeline, let the patient become stable, and then try to release the clamp and see from where the bleeding is going on and take care of the bleeding. If in these type of situations, sometimes we come across different type of situations where suppose because of that injury the abdominal wall is also open, or if abdominal wall is closed, major liver splenic injury, then we should go for a damage control surgery. Quickly do a patient selection, that is identify the patient, then try to stop the bleed, or at least do something to prevent infection going inside. Once you are able to control the bleed, maybe in this particular case you did a midline laparotomy, and because you were not able to identify from where the bleeding is going on, you have just put the packs. Packing has been done to control the liver bleed or the splenic bleed. And now shift this patient to the ICU. Give time to the patient for stabilization, where you will be pumping an IV fluid, blood transfusion, Trenexa. You will be monitoring the vitals, you will be monitoring the various lab parameters. Let the patient become stable. Once the patient becomes stable, then take the patient again for a definitive surgery, which will require maybe abdominal closures and other things. So in damage control surgery, because we have to save the life of the patient, we are not doing the definitive surgery early on. After identifying the patient, we focus on just controlling the bleeding and preventing the infection. Then we do the resuscitation in the ICU, make the patient stable, and then we do the definitive surgery. In these situations, we should also take care when we are trying to generate pressure in the pipeline. We should not increase too much pressure in the pipeline, because giving huge amount of fluid in the pipeline, increasing too much of pressure in the pipeline, whatever bleeding points were getting sealed with the platelets, clonic factors, because of the pressure, these bleeding points will not be sealing. So it should be a balanced hypotension. We try to maintain a pressure of 90 to 100 millimeter of mercury systolic pressure in these situations. Another scenario, suppose there is a blunt abdominal trauma, a car tire has run over the abdomen of some person, there might be splenic injury or so. There might have been some amount of bleeding, but the blood would have clotted immediately, and this clot is acting as a direct pressure and is preventing any further bleed, so patient is hemodynamically stable. Now this patient is taken to the hospital. If the patient is stable, first we do EFAST to look for whether there is any injury to any of the blood-filled organs, liver, spleen, kidney, and because the patient is stable, better than ultrasound would be a CECT. So we can do a CCT in a stable patient, but not in an unstable patient. And then, because there is no active bleeding, generally the treatment is non-operative, that is conservative. The same story applies everywhere in all types of traumas. Stable, unstable, how to handle these patients. Penetrating abdominal trauma, suppose somebody hits a knife in the abdomen. Now, if the foreign body is inside, then these foreign bodies should not be removed on the road. Patient should be taken in the OT, and these foreign bodies should be removed under full vascular precautions. However, if suppose somebody hits a knife in the abdomen, takes the knife out, now depending on what is the injury, suppose the knife has not penetrated the peritoneum, that means there is no peritoneal breach. No need to do a laparotomy, just do a simple wound exploration. But suppose the knife has breached the peritoneum and has gone into the peritoneal cavity, it might have caused some small mesenteric tear or maybe intestinal perforation, but patient is stable. If it is just a small mesenteric tear, the bleeding is going to stop. You just observe this patient in the hospital for 24 to 48 hours. Patient suppose does not develop any peritonitis or anything, then no laparotomy, nothing has to be done. You can discharge this patient. But if by chance the knife has perforated the intestine, the intestinal contents will leak in the peritoneal cavity, will cause peritonitis. If patient develop peritonitis, you have to do a laparotomy, do a peritoneal lavage and deal with the perforation accordingly. If this knife, which has gone inside the peritoneal cavity, has hit some major vessel, huge amount of bleeding, patient will not be stable. Patient will be unstable. An unstable patient, we follow the same guidelines, ABCDE. While ABCD is going on, do a EFAST, no time, nothing for CECT, and immediately take the patient in the operation theatre, open the area, apply direct pressure, stop the bleed, save the life of this patient. Retroperitoneal traumas. Retroperitoneum can be divided into 3 zones. Zone 1 is the central zone, where there is aorta and IVC. Zone 2 is the lateral zone for the kidneys, and zone 3 is the pelvic retroperitoneal zone. If the patient is unstable, that means major bleeding is going on, whether it is from this area or this area or this area. We follow the same guidelines, ABCD, EFAST. If not coming under control, open, direct pressure. If the patient is stable, then we do the EFAST. Ideally, we should do a CECT and treatment should be conservative. But zone 1 retroperitoneal traumas is an exception, because zone 1 is having IVC and aorta. There is a possibility there might be some injury to the IVC or the aorta, so blood clot has formed and it is preventing any further bleed and patient is stable. But because these are major vessels, high pressure, and this can dislodge the clot at any point of time and patient can die. So in zone 1 retroperitoneal traumas, we don't want to take any chances whether the patient is hemodynamically stable or unstable. We should do a surgical exploration in both the situations. Zone 1 always requires surgical exploration even if patient is stable, but zone 2 and zone 3 require surgical exploration only if patient is hemodynamically unstable. If we look at the thermal trauma burns, most common burns what we see in day-to-day life are the scalds caused by hot liquids. Most common burns in hospitals are the thermal burns or the flame burns. The pathophysiological changes happening in a burn patient are related to hypoxia, hypovolemia, and sepsis. We can assess the damage severity by percentage of burns and depth of burns. And in the management, pre-hospital management, then in the hospital, first basic resuscitation and then the definitive care of the burns. In the pathophysiological events, hypoxia can be because of thermal injury to the airways, which can lead to swelling of the airways. Like flame burns will cause more upper airway injury and steam burn will cause more lower airway injury. In burns, flame burns, the black carbon particles, soot particles can be inhaled, which can cause chemical alveolitis, alveolar edema, and lead to hypoxia. Toxins liberated in fire, most commonly carbon monoxide, second most commonly hydrogen cyanide, can cause hypoxia. Metabolic acidosis. A scar formation in deep burns over the chest wall interfere with the rib movements can lead to hypoxia. Burns can cause hypovolemia because burns can cause intensive inflammation, vasodilation, so there will be leak of intravascular fluid and heat to the extravascular space. First 24 to 36 hours is the most crucial period for hypovolemia. Later on, because we know that skin is the natural defense barrier which protects our body from the external microorganisms invasion, but in burns, if the skin is burnt, then outside microorganisms can invade easily inside, leading to severe infections. So most common source of infection in burns is the burnt wound itself, most commonly by Pseudomonas, second most commonly by Staph aureus. To assess the severity, we can calculate the total percentage burns, TBSA, total burns, total percentage of burns, total body surface area burn in percentage. Most commonly, we use Wallace rule of 9. According to this Wallace rule of 9, head and neck is given as 9%, front of chest is 9, back of chest is 9, front of abdomen is 9, back of abdomen is 9. Front of one lower limb is 9, back of one lower limb is 9. The complete upper limb is 9. So if we see this particular case, head and neck 9, front of chest 9, back of chest 9, front of abdomen 9, back of abdomen 9, one upper limb 9, one upper limb 9, front of one lower limb 9, back of one lower limb 9. So this is 99% and 1% is for the perineum. This is the Wallace rule. In case of children, the head and neck bear larger surface area as compared to the adult. At 1 year of age, the head and neck is taken as just double, 18%. And now we reduce 1% every year, so that at 10 years of age, the head and neck burn is 9%. We can take the help of Lund and Browder charts in children. Palm rule. In patchy distribution of burns, we can cut a piece of paper equivalent to the size of the patient's hand. Hand means the palm and the fingers, and that is taken as 1%. Depth of burn depends on temperature of the source and duration of contact. More the temperature, more the duration, more will be the depth. If we look here, this is the skin, where this is the epidermis and this is the dermis. Then there is subcutaneous fat, muscle, and the bone. If it is involving only the epidermis, it is first degree, dermis is second degree, subcutaneous fat, muscle or bone is third degree. However, according to ATLS, subcutaneous fat is third degree, muscle or bone is fourth degree. First degree burns, epidermal burns, they are just like sunburns or abrasions. No treatment is required, just exposure. They are not included in calculating the percentage of burns. Second degree burns can be classified as second degree superficial if superficial dermis is gone. They can be classified as second degree deep if deep dermis is gone. Blister formation is very common in second degree burns, and second degree deep burns are red, blotchy and velvety in appearance. Second degree deep burns, if the nerve endings are gone, they will be painless. That means first degree and second degree superficial are painful, but second degree deep, third degree or fourth degree, they'll be painless, right? We should not break the blisters because blisters are acting as sterile dressing and preventing any external contamination inside. Third and fourth degree burns or third degree burns, where skin is completely dead, we have to remove this dead skin and do a skin grafting, debridement and skin grafting. These third, fourth degree burns, they may be black or white, leathery in appearance. They are painless. In the management pre-hospital, the person who is going to save these burning people, he has to ensure his own safety first. Then he has to follow the protocol stop, drop and cool. Stop the burning process. If it is electrical burn, switch off the mains. Drop the burning person on the ground with the burning surface up according to ATLS. And cooling of the burn wound should be done with running water at room temperature. Ice should not be used because this burn patient is already losing intravascular fluid and heat outside. So he's already going into hypothermia. If ice is used, patient can die of hypothermia. Then these burning people have to be transferred to the hospital quickly. And in the hospital, the doctor's first duty is to save the life. So basic resuscitation, ABCDE, airway, Early endotracheal intubation is preferred in suspected airway burns. Breathing, if respiratory muscles are paralyzed, put the patient on ventilator. And then circulation, because there is huge amount of fluid which is leaked from intra to extravascular space, circulatory management will be crucial. Initial fluid of choice for basic resuscitation will be isotonic crystalloids like ringer lactate. Very close to ringer lactate is Hartmann's solution. We can even use normal saline. Colloids are best avoided in the first 12 hours. And we can give the fluid according to Parkland formula or according to ATLS guidelines as well. Bailey and the MCQ people uses Parkland formula. According to Parkland, 4 into percentage of burns into body weight in kgs. This gives us X ml of ringer lactate to be given in first 24 hours. As per ATLS guidelines, it is not 4, it is 2 into percent into weight in kgs. In children up to 14 years of age, 3 into percent into weight in kgs, and electrical burns 4 into percent into weight in kgs. Electrical burns will require more fluid resuscitation because electrical current, it can cause muscle damage, which will release myoglobin. Myoglobin will come in the pipeline, can cause myoglobinuria, can block the kidneys. So we have to be aggressive in the fluid management so that the kidneys will not be choked. If whatever fluid we are giving, we are able to generate sufficient pressure in the pipeline, then urine output will be adequate. But if the urine output is less, we have to increase the fluid infusion. If the urine output is more, then we have to decrease the fluid infusion. Whatever fluid you have calculated, whether it is Parkland or ATLS, this total amount of ringer lactate has to be given in the first 24 hours. Half of this fluid has to be given in the first 8 hours and the remaining half in the next 16 hours. Once airway, breathing, circulation. Airway, oxygen going down, breathing, lungs expanding, circulation, sufficient pressure in the pipeline, oxygen is supplied to the vital organs, life is saved. Now the definitive treatment for burn wounds. First degree burns, nothing. Second degree burns, we have to do dressing to delay the onset of contamination of the wound. Because in second degree burns, epidermis is gone, dermis is exposed. High risk of invasion of external microorganisms inside. So cover that wound with dressing to prevent any external invasion. We can use just paraffin gauze dressings. We can use silver sulfadiazine, most commonly used, 1% concentration. We can use mupirocin, mefenide acetate, but mefenide acetate is painful, causes metabolic acidosis. Serum nitrate solution can be used, collagen sheets can be used, fish skin can be used. For third and fourth degree burns, where the skin is completely dead, we have to remove the dead skin debridement and do a skin grafting. In skin grafting, if we are taking the skin graft from the same person, it is autograft. From identical twins, isograft. Same species, allograft. Different species, xenograft. Auto, iso, allo, xeno. Auto, same. Iso, identical twin. Allo, same species. Xeno, different species. We use a Humbee's knife and wolf blade in skin grafting. This is Humbee's knife. We can also use a dermatome. And depending on what is the gap between the blade and the rod, we can adjust that gap with the screws, and we can take a thin slice or a thick slice. Partial thickness skin graft, that is called as a split skin graft or a Thiersch graft, which is composed of epidermis and superficial dermis, while full thickness skin graft, which is called as wolf graft, this is composed of complete skin, full thickness skin, that is epidermis and complete dermis. Most commonly we use partial thickness skin graft or split skin graft. And most commonly this split skin graft is taken from the thigh, the anteromedial aspect or the anterolateral aspect. After taking the skin graft, the donor site is covered with bandaging and a new skin will come up in 2 weeks' time. In full thickness skin graft, generally we take it from the post-auricular area or the supraclavicular area and the donor site will require suturing. A partial thickness skin graft can be expanded to cover a large area. Like we are seeing here, we can create holes in the partial thickness skin graft, which will help in expanding the skin graft. You see, we have created holes inside. Here you see, this is a partial thickness skin graft or a split skin graft. Why these holes? One, it will help in expanding the graft. Second, more amount of granulation tissue can come through this, which will help in better fixation of the skin graft. This is a measure which can be used to create holes in the skin graft. The only problem with partial thickness skin graft is they contract more, so cosmetic outcome is poor. While full thickness skin graft cannot be expanded, so they cover only small areas, but the graft contraction is less, cosmetic outcome is good. So for face, we prefer full thickness graft. Another type of graft can be composite graft, where not only the skin, but we take fat or cartilage also, especially when we have to put it on the ala of the nose or maybe the eyebrows. We use composite grafts. Whenever we are putting the skin graft at the recipient site, how this skin is going to survive? In the first 48 hours, there is plasma imbibition of nutrients from the underlying surface. Third day, inosculation occurs, where bridges develop from the skin graft and the underlying surface, and gradually new vascularization occurs, and by 5th day the skin graft settle at the recipient site. We should not put the skin graft if there is any infection at the recipient site, especially with beta hemolytic streptococci, otherwise it will eat up the skin graft. We cannot do the skin grafting on a bare bone or a cartilage or tendon. Other surgeries which can be done in burn patients sometimes, in deep burns where a scar has formed, it can act as a tourniquet, especially if it is circumferential, and this can lead to compression of the vessels underlying. So we need to do a scarotomy, where we have to incise the skin, a longitudinal incision, so that it does not act as a tourniquet. In crush injuries or maybe in electrical burns, when there is significant muscle injury, it may lead to compartment syndrome type of story, and there we have to do a fasciotomy. Like this, what we are seeing, this is a fasciotomy. We are not just cutting the skin, we are cutting the subcutaneous tissue along with the fascia, so that the muscle which was under pressure, now the pressure has gone, and the chances of gangrene to the distal part will be less. So we can do a scarotomy in a scar when it is acting as a tourniquet. We can do fasciotomy in compartment syndrome, especially in electrical burns. For nutrition, enteral nutrition is the best. It should be started within 6 hours unless it is contraindicated. No role of prophylactic antibiotics in burns, and physiotherapy should be started on day 1. Otherwise, there can be post-burn contracture. However, if skin grafting has been done, then graft takes 5 days to settle at the recipient site. So in those cases, physiotherapy should be started after 5 days. Most common cause of immediate death in burns is suffocation, asphyxia, early death, hypovolemia, late death, sepsis. Electrical burns, there can be muscle injury, rhabdomyolysis, myoglobinuria, acute renal failure can occur. Electrical current can interfere with the pacing of the heart, so ECG is mandatory. Treatment would be aggressive fluids, ECG, compartment syndrome to be managed by fasciotomy, urgent fasciotomy. Chemical burns, acid-alkali burns are more dangerous. The treatment would be irrigation with running water at room temperature for long duration, 20 to 30 minutes. No role of neutralizing agent. It should not be, if there is an acid burn, then you are putting the alkali. In powder chemical burns, just remove the powder with a brush. Cold burns can be because of dry or wet. Dry cold causes frostbite, and wet cold causes trench foot or non-freezing injury. The basic difference between frostbite and non-freezing injury or trench foot is the dry and the wet, and in frostbite, there is complete microvascular occlusion. While in trench foot, it is an alternating spasm and dilatation of the microvessels. The frostbite wound becomes white, hard, numb, and cold, while in trench foot, it shows signs of inflammation, like there may be Rubert tumor, dollar type of thing, ecchymosis, ulcerations. Here, frostbite, the chances of gangrene would be more. In the treatment for these cold injuries, we should do a rewarming at 40 or 42 degrees centigrade in warm water bath for 20 to 30 minutes. We can give aspirin, which can increase the flow of blood to the affected site. Surgery, especially in frostbite cases, should not be done early because it takes time for a clear line of demarcation to develop between viable and non-viable parts, maybe weeks or months. Then only amputation has to be done for the dead part. Right. Right. If we take a look at the trauma, first of all, polytrauma, where we'll be trying to save the life. Then we'll be discussing about head, chest, abdominal trauma, face, ENT, neck, orthopedics, and limb trauma in orthopedics. So first, let us see a polytrauma story. Suppose there is a disaster story, building collapse. The National Disaster Management Authority in India, whose head office is in New Delhi, has laid down certain guidelines. As soon as you receive the information of disaster, immediately you have to send quick response teams to the disaster site, which comprises of paramedical staff, maybe the staff nurse, the ward boy, ambulance driver, and they provide first aid to the patients. They immediately try to clear the airway, maybe any mud, dirt from the mouth or the nose. Any active bleeding, they apply some tourniquet to control bleeding. Any fracture, they try to stabilize the fracture, neck fractures, the cervical collar, like that, and transfer the patients quickly to the hospital. In the hospital, you carry out the emergency severity index. You have to save the life of these injured people. We are doing the triage at every step, segregating the patients into different categories depending on the requirements. Now, to save the life, primary assessment, we focus on A, B, C, D, E. A for airway, B for breathing, C for circulation, D for disability, E for exposure. To save the life of this patient, we want that oxygen should be reaching to vital organs. So we have to secure the airways, laryngeal mask airway, endotracheal intubation from the mouth or the nose. Nasal intubation is contraindicated in anterior cranial fossa fractures. If we cannot access the airway from the mouth or the nose, like in maxillofacial trauma or maybe huge amount of edema in this area, then we secure the lower airways, maybe a tracheostomy. But if we do not have the time to put the tracheostomy, then we can at least do a needle cricothyroidotomy using a wide bore needle, 14 gauge needle. We can even do a cricothyroidotomy. This is how the airway is secured so that oxygen goes into the balloons. Whether the balloons are expanding or not. Like in chest trauma stories, if suppose there is a rib fracture which has caused injury to the pleura of the lung, there may be collection of air in the pleural cavity pneumothorax, or the fractured rib has caused injury to the blood vessel, there may be bleeding in the pleural cavity hemothorax. If this is putting pressure only on one lung, patient is not going to die because the other lung is normal and oxygen is going into the pipeline. However, in these cases, because we want this ipsilateral lung to expand normally, so we can put the intercostal tube, drain the collection, advise breathing exercises which will expand the lung. Some cases, there is huge amount of air collection in the pleural cavity, tension pneumothorax, wherein this is not pressing only the ipsilateral lung, but it is causing mediastinal shift, which is causing the opposite lung under pressure. If both the lungs are getting collapsed, oxygen is not going inside, patient will die very soon. We don't have the time to put the tube. Wide bore needle should be put inside. Try to decompress, get 10, 15, 20 minutes, and then put the tube. Sometimes, like in burns, if there is respiratory muscle paralysis, then put the patient on artificial lung machine or ventilator. Once you have achieved adequate lung expansion, then the pipeline story. In bleeding cases, the volume in the pipeline is going down, pressure in the pipeline is going down, oxygen supply to the vital organs is going down. So you have to generate pressure in the pipeline. IV fluids, prefer crystalloids, especially in the initial period, because colloids are something which have got protein. If you give a colloid solution, when colloid leaks out from the site of leak, colloid in the extravascular space, protein in the extravascular space will exert oncotic pressure and will drag more intravascular fluid into the extravascular space. Thus will aggravate hypovolemia. So crystalloids are preferred, normal saline. In metabolic acidosis situation, we can use ringalactate, or very close to ringalactate is Hartmann's solution. To generate pressure in the pipeline, we give a fluid challenge where we push 1 liter normal saline within 1 hour. Whenever there is hypovolemia, the earliest sign is tachycardia. Heart tries to compensate so as to supply oxygen to the vital organs. Those areas in the body which are not vital for life, like skin, GIT, muscles, their vessels constrict, so the blood is diverted to the vital organs. Cutaneous vasoconstriction is an early sign of hypovolemia. Initially, these compensatory mechanisms are trying to generate pressure in the pipeline, but if more than 30% of pipeline volume is lost, then the systolic blood pressure starts dropping, hypotension. Earliest sign of hypovolemia is tachycardia. Cutaneous vasoconstriction is an early sign, but hypotension is a late sign of hypovolemia when more than 30% of fluid or blood loss has occurred. When we have to generate pressure in the pipeline, we are giving this normal saline. We put 2 wide bore IV cannulas so that if one gets blocked, the other is patent. And to have these wide bore cannulas, or to choose the cannula, there is a color coding of the cannula. If you look from the core of the mother earth to the sky, orange, gray, green, pink, blue, yellow, violet. 14, 16, 18, 20, 22, 24, 26. 14, 16 wide bore cannulas shock patients. Green, 18 gauge, adult males. Pink is the color of females, 20 gauge. 22 blue, children. 24 yellow, infants. 26 violet, newborn babies. Now, when you have put this orange or gray cannula and you are giving good amount of normal saline quickly, if you are able to generate sufficient pressure in the pipeline, sufficient fluid will be going to the kidneys and the urine output will be adequate. The minimum urine output which we should be able to achieve in case of adults more than 0.5 ml per kg per hour, though normal is 0.5 to 1 ml per kg per hour. In children, more than 1 ml per kg per hour, and in infants, more than 2 ml per kg per hour. If the urine output is less, increase the fluid infusion. If urine output is more, decrease the fluid infusion. When we are pumping in this fluid, if suppose there is more than 30% of blood loss in a trauma patient, simply giving the normal saline will not help, because there will be more than 30% of RBC hemoglobin loss. More than 30% of WBC platelet clotting factors are lost. If more than 30% of hemoglobin is lost and you are trying to generate pressure only with normal saline, You may be able to create the pressure, but if hemoglobin is less in the pipeline, who will carry the oxygen to the vital organs? So you have to give RBC hemoglobin. You want the bleeding to stop, so you need platelets, clotting factors. We don't need WBC. So we do create a leukodepleted blood fraction and we transfuse it. We also give injection of tranexamic acid, which help in aggregation of platelets, clotting factors to stop the bleed. First dose of tranexamic acid should be given within 10 minutes, preferably within 3 hours. Second dose should be repeated within 8 hours. If by giving normal saline blood Trenexa, the bleeding has stopped, patient vitals have become stable, wonderful. No active intervention at this point of time. You can do the investigations and all. If even after pumping a normal saline blood Trenexa, the pressure in the pipeline is not coming up because there is a major bleed. Whatever you are pumping in, that is leaking out. In these cases, oxygen is not getting supplied to the vital organs and this patient is going to die quickly. Do not wait. Open the area which is bleeding. Apply direct pressure. Best method to control bleeding is direct pressure. After stopping the bleed with direct pressure, now ask your assistant to pump in normal saline, blood, Trenexa. Now try to generate pressure in the pipeline and this will supply oxygen to the vital organs. That is how the C circulation story has to be approached. D is disability. We assess whether oxygen supply to the brain is adequate or not only in trauma, not only in bleeding situation, but any situation where there is volume loss, maybe vomiting, diarrhea, or maybe some acute pancreatitis type of situation, peritonitis type of situation, where there is huge amount of fluid loss, patient is in shock. All the lovely doctors can understand if the volume in the pipeline is going down, pressure in the pipeline is going down, patient may die. Oxygen supply to the brain is going down, so brain responses can become abnormal. And to check these brain responses, we measure a Glasgow Coma Scale. So Glasgow Coma Scale is not only for head injury or something like that. It is for all those situations where oxygen supply to the brain is less, whether it is related to vomiting or to diarrhea or to bleeding or to peritonitis or to acute pancreatitis. Now to assess the brain response Glasgow Coma Scale, we measure 3 parameters: EVM, electronic voting machine, I, verbal, motor. Maximum I 4, verbal 5, motor 6, minimum 1, 1, 1. Total maximum GCS 15, total minimum GCS 3. Mild, moderate, severe, 13 to 15 mild, 9 to 12 moderate, 8 or 8 less than 8 severe. To remember, late night movie show 9 to 12, Chalti Kya 9 se 12. This is moderate. So 13 to 15 will be mild, 8 or less than 8 will be severe. How to assess these responses like high response? If sufficient oxygen is going to the brain, patient may be opening his eyes spontaneously, I4. If sufficient oxygen is not going to the brain, patient may be drowsy, his eyes may be closed. Give him a voice command or sound command. आँख खोलिए. If he opens his eyes on voice command, I3. If he does not open his eyes on voice command, give him a painful pressure stimulus. If he opens his eyes on this is E2. And if he does not open his eyes even on this painful pressure stimulus, it is E1. Verbal responses: if he is fully conscious, oriented to time, place, person, verbal 5, confused 4. If we start using inappropriate words, abusive language, verbal 3. If he is not able to speak out any words, but he is just making some sounds, verbal 2. If no sound, verbal 1. Motor commands, motor responses. If he is obeying all the commands, suppose you ask him to raise the right upper limb, he raises it. He is obeying your commands, motor 6. But if he does not obey the commands, give him a pinchy stimulus. If he localizes that pinchy stimulus, this is motor 5. If he is not able to localize this, but he tries to withdraw normal flexion movement, motor 4. Normal flexion movement, motor 3. Extension movement, motor 2. No movement, motor 1. If we are not able to test any response, we write it as NT, non-testable. If there is variation in the response on two sides, then better response is considered. For prognosis, we use motor score. E is exposure. We should not be shy. We should expose the patient completely, remove all his clothes, because many times, if underclothes have not been removed, the doctors have missed pelvic fractures, which may be having 2 to 2.5 liters of blood in the pelvis. So we have to expose the patient, but my dear friends, we need to take care that in all these situations, maybe vomiting, diarrhea, or acute pancreatitis, peritonitis, or any bleeding story, it is not only that the volume is going out, heat is also going out from the patient's body. So patient is going into hypothermia. When you are removing his clothes, cover the patient with warm blanket, and whatever IV fluid you are giving, they should not be cold, they should be warm. This will prevent hypothermia. At every step, we are doing the triage, segregating the patients into different categories. Patients where the injury is immediately life-threatening will require immediate intervention. They are in red category. Patients where the injury is not immediately life-threatening, patient can wait, patient is a bit stable. They are yellow categories. Patient who is an ambulatory patient and he does not have any serious injury at all may require a little bit of hospital care, green category. And if the patient is moribund or maybe pulseless or dead, that means a patient wherein the condition is such that whatever best efforts you do, you will not be able to save the life of this patient, then don't waste your precious time in these patients. These are black category patients. White category is crudely used for an ambulatory patient who has come to the hospital, no injuries, no hospital care is required. Once we have secured the airways, expanded the lungs, generated sufficient pressure in the pipeline, oxygen is going to the vital organs, brain response is fine, no hypothermia. That means patient is stable. Now you have got all the time where you can take a detailed history, detailed clinical examination, special investigation, X-ray, CT, endoscopy, contrast studies, and definitive treatment. So this is secondary survey. When you are taking the detailed history, do not forget about AMPL, A for allergy, M for medication, P for past illness pregnancy, L for last meal, and E for events of injury. If patient is taking any medicines which increase the risk of bleed, stop those medicines immediately, and sometimes you have to give counter medicines like patient on aspirin have to be given platelets, patient on warfarin, vitamin K FFP has to be given, patient on heparin protamine sulfate has to be given. We commonly use the term shock, bleeding, blood transfusions. Shock simply means less oxygenation of the tissues or hypoperfusion of the tissues, inadequate organ perfusion and tissue oxygenation. Depending on who is the culprit for not supplying oxygen to the vital organs, we can classify the shock into cardiogenic, hypovolemic or hemorrhagic, distributive, obstructive, and endocrine. If heart is not able to pump, maybe because of MI or maybe trauma to the heart, it is cardiogenic shock. If there is leak in the pipeline, that is hemorrhagic or hypovolemic shock, where tachycardia is the earliest sign, that is the commonest type of shock in trauma situations. Distributive shock, where the blood in the body is getting distributed. Like if we talk about infections, whenever there is any acute inflammation, vasodilatation, more blood will be going to the inflamed organ. So blood from the other areas will be diverted towards the inflamed organ. The other areas will be receiving less oxygen. Hypoperfusion. This is distributive shock. Or maybe in situations, for example, if there is any trauma to the brainstem or the cervical spine, there may be sympathetic blockade. And in these situations, the blood will remain pooled in the capacitance veins. So, other areas in the body are not getting sufficient oxygen. This is distributive shock. Obstructive shock is when there is massive collection in the thorax, which is pressing the vena cava, because of which blood is not going into the heart, so heart is not able to pump the oxygen. Like in cardiac tamponade, when there is huge amount of blood around the heart, it will compress the superior and inferior vena cavas, which will cause pooling of blood in the neck and the facial veins. Or in tension pneumothorax, huge pressure in the mediastinum, compress the superior and inferior vena cavas, blood is not going into the heart. This is obstructive shock. Sudden release of hormones can lead to endocrine shock. Bleeding, to measure the amount of blood loss, various crude methods. Clot in a clenched fist 500 ml. Blood loss in closed fractures like humerus tibia 750 ml. Femur 1500 ml. Pelvic fractures 2000 to 2500 ml. We can categorize the blood loss into 4 categories: 0 to 15, 15 to 30, 30 to 40, more than 40. 0 to 750 ml, class 1. 750 to 1500 ml, class 2. 1500 to 2000 ml, class 3. And more than 2000 ml, class 4. To assess in which category the patient is falling, we can take the help of 5 basic parameters: pulse, respiratory rate, systolic blood pressure, urine output, and GCS. We know that systolic blood pressure starts falling after 30% of blood loss. That means class 1 and class 2, 0 to 15, 15 to 30, systolic pressure is normal. And if pressure in the pipeline is normal, sufficient fluid is going to the kidney, urine output will be normal. If pressure in the pipeline is normal, sufficient oxygen is going to the brain, so GCS will be normal in class 1 and class 2. But in class 3, when systolic blood pressure starts falling, urine output and GCS will also start dropping. And in class 4, marked drop in systolic pressure will cause marked decrease in urine output and GCS. Urine output may almost be negligible in class 4 blood loss. While pulse and respiratory rate in class 1 will be normal, class 2 there will be tachycardia and tachypnea, like 100 to 120 in class 1 pulse rate and 20 to 30 respiratory rate in class 1. Class 1 pulse rate will be less than 100 normal, respiratory rate less than 20 normal. Class 2 pulse rate tachycardia 100 to 120, respiratory rate 20 to 30. Class 3 pulse rate 120 to 140, respiratory rate 30 to 40. Class 4 pulse rate more than 140, respiratory rate more than 40. More than 35 basically in respiratory rate in class 4. Whenever we talk about blood losses, the best or the ideal replacement for blood loss is blood transfusion. And whenever blood transfusion is done, we know that when we are taking blood from the donor, it is stored in the blood bank in the refrigerator at 4 degrees centigrade plus minus 2 degrees centigrade. And we are using Sagam anticoagulant, where the shelf life of the blood increases to 5 weeks. Sagam, sodium chloride, adenine, mannitol, and glucose. Complications of blood transfusion can be transfusion reaction, like mismatched transfusion. Wrong blood is transfused due to clerical error. Most common symptom if wrong blood is transfused is heat and pain sensation along pain and heat sensation along the vein. If mismatched transfusion is done, there will be antigen-antibody reaction in the pipeline. Large clumps will form which can choke the kidneys. The urine output will decrease, oliguria. There can be hemoglobinuria as well. In an anesthetized patient, if the surgeon sees generalized oozing of blood from the cut surfaces, that also gives an idea about mismatched transfusion. Because in wrong transfusions, the filter is getting choked, we have to give diuretics to clear the kidneys. If this doesn't help, we'll end up in doing dialysis for these patients. Various infections can be transmitted through blood like hepatitis B, hepatitis C, HIV, malaria, syphilis. Massive blood transfusion. In massive bleeding situations, we might have to give massive transfusions. More than 10 units of packed RBCs given within 24 hours, or more than 4 units of packed RBCs given within few hours or 1 hour. This is massive transfusion. And it can lead to complications like uh, congestive cardiac failure due to volume overload, more commonly in anemic elderly people. There can be hyperkalemia in the recipient due to lysis of RBCs. Potassium will be released. Huge amount of potassium can lead to hyperkalemia in the recipient. The chelating agents which we use, they can bind with the recipient ions like calcium, magnesium, potassium, and they can cause hypocalcemia, hypomagnesemia, hypokalemia. Massive transfusions, because we don't get sufficient time to warm the blood, patient can land up in hypothermia. Because in the stored blood the cells are getting lysed, so we may not be getting sufficient viable platelets and clotting factors, which can cause relative deficiency of platelets in the recipient, thrombocytopenia, relative deficiency of clotting factors in the recipient, dilutional coagulopathy, or disseminated intravascular coagulopathy, which should be treated by fresh frozen plasma. Fresh frozen plasma is a rich source of clotting factors. FFP is stored at minus 40 degrees centigrade and its shelf life is 2 years. The stored blood has a acidic pH of 6.3. Massive transfusion can cause metabolic acidosis in the recipient. These were the basic stories in trauma situation. Now we come to the organ-specific traumas: head, chest, and the abdomen. Head, scalp, skull, brain. CSF and skull, they both protect the brain. In the scalp, most dangerous zone, loose irregular tissue, because emissary veins are going from the loose irregular tissue into the brain. So scalp lacerations should not be taken lightly. We should irrigate them nicely, thoroughly with normal saline, and suture the scalp wound in 2 layers, the galea aponeurosis and the skin. Skull fractures, linear fracture, blunt trauma, depressed fracture, penetrating trauma like hammer. Base of skull fracture, base of skull can be divided into anterior, middle, posterior cranial fossa. In the anterior cranial fossa, most commonly cribriform plate is injured, or the ethmoid bone, which can lead to CSF rhinorrhea confirmed by beta-2 transfer in protein, target sign, halo sign. And in anterior cranial fossa fractures, we can find raccoon eyes or panda sign, bluish, brownish, blackish discoloration around the eyes. Middle cranial fossa fracture, it is the petrous part of the temporal bone most commonly injured, presenting with CSF autoria, and we may find Bettel sign, bruising or brownish discoloration at the mastoid. Bettel sign more often seen in middle cranial fossa fractures, but can be seen in posterior cranial fossa fractures also. Pons fracture is like a dent on the ping pong ball in children. Orbital blowout fractures, most commonly it is the floor or the inferior wall of orbit. Second most commonly it is the medial wall of the orbit. In the brain injuries, there can be coup and counter coup injuries. Coup is injury at the site of impact. Counter coup is injury remote from the site of impact. And counter coup is common when the head is in motion. In brain injuries, there can be different type of hematomas like intracerebral, extradural or epidural, subdural, subarachnoid, cerebral herniation, and so on. Extradural or epidural hematoma is collection of blood between the dura mater and the periosteum. Commonly seen in the temporoparietal region, pterion, middle meningeal artery injury, which is a branch of maxillary artery. Transverse sagittal sinus injury can also lead to this. Extradural hematoma is farthest hematoma from the brain parenchyma, so it may take some time to put pressure on the underlying brain parenchyma, wherein the patient can remain normal. Transient period of consciousness after trauma, where the patient can carry out normal routine activities before losing his consciousness. This is lucid interval, commonly seen in extradural hematomas. Extradural hematomas on CT scan, non-contrast CT scan, they appear hyperdense biconvex like an idli or a lens, lenticular. Subdural hematoma, also called as Boxer's hematoma. This is commonly seen in the frontal or the frontoparietal region due to injury to cortical bridging emissary veins, and we can classify subdural hematoma into acute, subacute, and chronic. First 3 days acute, 4 to 21 days subacute, after 21 days chronic. And subdural hematoma on non-contrast CT shows a hyperdense concavo-convex like a banana or a crescent. In the management of head injury, whatever is the hematoma, extradural, subdural, or maybe intracerebral, this is going to increase the intracranial pressure, because of which the cerebral blood vessels can constrict, cerebral perfusion pressure can decrease, and oxygen supply to the brain parenchyma can be hampered. The duration of hypoxia to the brain parenchyma is directly proportional to irreversible brain damage. So we don't want hypoxic damage to the brain parenchyma, otherwise that portion of the brain will be permanently damaged. That is the reason why in all head injury patients, our focus is to reduce the intracranial pressure. Normal intracranial pressure is 8 to 12 millimeter of mercury. More than 22 can be dangerous. So our target is to keep the intracranial pressure less than 20 millimeter of mercury, so that cerebral perfusion pressure, which is mean arterial pressure minus intracranial pressure, can be kept above 60 millimeter of mercury and prevent irreversible damage to the brain parenchyma due to hypoxia. To reduce this intracranial pressure, we can give diuretics, we can give mannitol. Mannitol is the osmotic diuretic of choice in brain edema. But mannitol must be used with caution in large intracranial bleeds, because mannitol can cross the blood-brain barrier, it can go into the site of bleed and exert oncotic pressure, drag more blood from intravascular to extravascular space, increasing the size of bleed. However, better than these, to reduce the intracranial pressure, you can drill a hole through the skull into the brain, burr hole, or even better is a decompressive craniotomy and evacuate the hematoma. Lumbar puncture to reduce the intracranial pressure is best avoided. Fluid management is not that aggressive in brain injuries or brain hematomas, because even if there is a brain hematoma, it cannot be so large due to skull that it will lead to hypovolemic shock. But if fluid has to be given in head injury patient, we can give normal saline, ring-elected, hypertonic saline, but glucose-based solutions should be avoided. Dextrose solutions should be avoided because hyperglycemia is harmful to brain. In the chest trauma, most common part injured are the ribs, 4th to 9th ribs on the left side. And we can find a pneumothorax story, hemothorax story, hemopneumothorax story, sometimes tension pneumothorax story, sometimes a sucking wound of the chest or open pneumothorax, or sometimes a flail chest. If we look at the pneumothorax or hemothorax or hemopneumothorax, if the rib fracture has caused pleural or lung injury, air in the pleural cavity pneumothorax, rib fracture, blood vessel injury, blood collection in the pleural cavity, hemothorax. If whether it is pneumo or hemo or both hemopneumo, if they are putting pressure only on one lung, that means the other lung is normal and oxygen is going through the other lung into the pipeline. Patient is not going to die. Patient is presented with mild difficulty in breathing. We have got sufficient time to do the examination, investigation, and treatment. Now, in our clinical examination, percussion is important. Percussion is done with middle finger on the middle finger, and the movement in percussion occurs at the wrist joint. If you hear a loud tympanic note, resonant note, it is air. If you hear a dull note, it is fluid. We can do the auscultation. Now, if the lung is collapsed, those areas where lung is not present, breath sounds will be absent. Those areas where the lung is present, breath sounds will be there. So diminished absent breath sounds also can guide us. We can do a chest x-ray. If we see hyperlucency or more blackness, this is pneumothorax. If we see white haziness with blunting of the costophrenic angle, this is fluid, hemothorax, or maybe hydrothorax. If there is any doubt, we can do a CT scan. And the treatment here would be, problem is only one lung is under pressure. You have to drain the collection from the pleural cavity, create a space, advise breathing exercises for lung expansion. To drain the collection from the pleural cavity, intercostal tube drainage, generally in the 4th or 5th intercostal space in the triangle of safety, just anterior to the mid-axillary line, along the upper border of the lower rib, 28 to 32 French catheter. Outer end of the catheter is dipped in underwater seal bag. Drain the collection. Breathing exercises with spirometer or maybe football bladder, generally spirometer, and the lung can expand. Sometimes when we are doing a tube thoracostomy or intercostal tube drainage, if huge amount of blood is coming out through the tube outside, say more than 1.5 liter of blood within 1 hour, that is more than 20 ml per kg in 1 hour, or more than 200 ml per hour consecutively for more than 2 to 4 hours. That is more than 3 ml per kg, uh, like this. For major tracheobronchial esophageal ruptures, we need to do an immediate thoracotomy. If it is a bleeding story, we have to apply direct pressure, stop the bleed, and save the life. Sometimes we come across tension pneumothorax type of situation when there is massive air collection in the pleural cavity, which is not only causing ipsilateral lung to collapse, but it is causing mediastinal shift, and the opposite lung is also under pressure. In these cases, there may be compression of the vena cavas, which will cause pooling of blood in the neck facial veins, so these veins will get dilated, tortuous, raised jugular venous pressure. Because no blood is going into the heart, or less blood is going into the heart will not be able to generate pressure in the pipeline, hypotension. And in these cases, because of the lung collapse, the breath sounds will be diminished or absent. This is a dire emergency situation because both the lungs are collapsed. So oxygen is not going into the pipeline and patient will die. We do not have the time to put the tube. We just put a needle, wide bore needle insertion, maybe a 14 gauge needle or whatever wide bore is available. You can put it in the 4th, 5th intercostal space just anterior to the mid-axial line in adults. In children, it can be put in the 2nd intercostal space in the mid-clavicular line. Though, even in adult, we can put it in the 2nd intercostal space in the mid-clavicular line. Try to decompress. Try to get 10, 15, 20 minutes, save the life, and then do a tube thoracostomy, intercostal tube drainage and breathing exercise. Tension pneumothorax should be differentiated from cardiac tamponade, where there may be cardiac injury and blood around the heart, which is not allowing the heart to contract. The vena cavas may be compressed, leading to neck, face veins, engorgement, raised jugular venous pressure, hypotension, and because of fluid around the heart sounds will be muffled, but the breath sounds will be normal. Earlier, we were doing a needle pericardiocentesis in cardiac tamponade, but now no needle. We should do an immediate thoracotomy and take control of the bleeding from the heart. Sucking wound of the chest or open pneumothorax. Somebody hits a knife in the chest and takes the knife out. If there is a more than 3 centimeter size wound, there may be a communicating wound between the pleural cavity inside and the outside atmosphere. Outside pressure is positive, inside pressure is negative, so continuously outside air will be sucked inside, which can lead to huge amount of air collection inside. Not only one lung under pressure, but mediastinal shift, opposite lung can also be under pressure. This is again a dire emergency type of situation. Immediately what we can do is to prevent outside air from going in, we can put some silver foil or maybe a paper type of thing on the chest wound. Do a taping on 3 sides so that it can act as a valvular dressing. It will not allow the outside air to go in, but whatever air has gone inside, that will come out through that open area where taping has not been done, taping has not been done. And then you have to put the intercostal tube drainage and breathing exercises for lung expansion. Flail chest is 3 or more than 3 consecutive rib fractures at 2 or more than 2 sites. Flail segment shows paradoxical respiration, and this is also a dire emergency. We give intermittent positive pressure ventilation not to allow the flail segment to injure the lungs, but immediate surgery will be required for fixing those flail segments. So overall, dire emergency condition in chest trauma would be tension pneumothorax, open pneumothorax or second wound of the chest, flail chest, cardiac tamponade. Best investigation in all trauma situations would be CT scan. In the abdominal trauma, blunt abdominal trauma most commonly spleen, second liver. Penetrating abdominal trauma most commonly liver, second small intestine. Seatbelt abdominal trauma, whiplash injury, mesenteric tears, mesenteric injuries, and gut ischemias, intestinal ruptures, bomb blast explosion, air-filled cavities from top to bottom in a sequence, eardrum or tympanic membrane, trachea, lungs, intestine. In abdominal trauma, suppose a car tire has run over the abdomen, blunt abdominal trauma. There might be significant injury to the spleen or liver, huge amount of bleeding, volume in the pipeline going down, pressure in the pipeline going down, oxygen supply to the vital organs going down, patient can die. In the emergency, To save the life, basic resuscitation, ABCD, secure the airway, see that breathing is normal, and then pipeline management, increase pressure in the pipeline. If despite pumping in normal saline blood Trenexa, there is a major leak, suppose pressure in the pipeline is not coming up, now don't wait. Open the abdomen by midline incision, because midline has the fastest access and equal exposure on both sides can be there. And as soon as you open the abdomen, if you see huge amount of blood and you're not able to understand what is the source of bleeding, from where this bleeding is coming up, you can simply put your thumb index finger in the foramen of Winslow in the hepatoduodenal ligament, where there will be portal vein and the hepatic artery, or you can put a clamp in the foramen of Winslow hepatoduodenal ligament to block the portal vein hepatic artery so that the liver bleed can stop. This is Pringle's maneuver. Pringle's maneuver. However, when this patient was brought to us in the emergency and ABCD was going on, if we have the facility of ultrasound there in the emergency, we can quickly do E-fast in the emergency when resuscitation is going on. FAST is focused assessment by sonography in trauma, where we scan the epigastrium for pericardial fluid, right hypochondrium for liver, right kidney, left hypochondrium for spleen, left kidney, and pelvis for any free fluid in the peritoneal cavity. Now, not only the abdomen, we can extend this FAST to scan the thorax for bilateral pleural collections. That is called as E-fast or extended FAST. Diagnostic peritoneal lavage has become obsolete and we don't do it nowadays. If suppose blunt abdominal trauma, there was some minimal injury of the spleen or the liver, small amount of bleeding, blood is clotted and is preventing any further bleed, patient is hemodynamically stable, we should admit this patient for observation in the hospital maybe for 24 or 48 hours. We can do the E-fast to see whether any organ injury is there or not. If suppose we find there is some injury in any of these organs, then we do CECT. Because patient is stable, we can do a CECT in a stable patient. And treatment in a special patient is generally conservative, that is non-operative. In penetrating abdominal traumas, if suppose the foreign body is inside, then we have to remove this foreign body in the operation theatre under full vascular precautions. If somebody hits a knife in the abdomen, takes the knife out and runs away, depending on whether patient is stable or unstable. If suppose the knife has not breached the peritoneum, that means patient would be stable. If knife has breached the peritoneum but has caused only some mesenteric tear, not significant bleeding, patient will be stable. If knife has breached the peritoneum and has caused maybe small intestinal perforation, again this patient will also be hemodynamically stable. But if suppose knife has breached the peritoneum and it has hit the major vessels, huge amount of bleeding going on, patient will be unstable. Depending on the situation, we will play accordingly. If the patient is stable and there is no peritoneal breach, no need of any laparotomy, just wound exploration. If patient is stable but peritoneal breach is present, maybe because of omental or intestinal prolapse, then we have to admit the patient for observation for 24-48 hours in the hospital. Look for any signs, symptoms of peritonitis coming up. No peritonitis, no laparotomy. If peritonitis, we have to do a laparotomy, peritoneal lavage, and deal with the perforation accordingly. If there is knife injury and patient is unstable, huge amount of bleeding going on, follow the same guidelines, ABCD, basic resuscitation, E-fast, and despite pumping an IV fluid, blood Trenexa, if the pressure in the pipeline is not coming up, do not wait, open the area, apply direct pressure, control the bleed and save the life of this patient. Retroperitoneal traumas. Retroperitoneum can be divided into 3 zones. Zone 1 is the central zone for the aorta and IVC. Zone 2 is the lateral zone for the kidneys, and zone 3 is the pelvic retroperitoneum. Patient of retroperitoneal trauma, if he is hemodynamically unstable, then all the lovely doctors know we'll follow the same guidelines, ABCD, E-fast, and then surgical exploration, direct pressure to stop the bleed. So if patient is hemodynamically stable, generally we know that patient will not require any operative intervention. But zone 1 retroperitoneal trauma is exception because there is aorta IVC. Patient may be stable, maybe because there might have been a small clot which is acting as pressure and stopping any bleed from aorta IVC. But because these are major vessels, this clot can dislodge at any point of time, so we don't want to take any chances in zone 1 retroperitoneal trauma. Even if the patient is stable, we should do surgical exploration in zone 1 retroperitoneal traumas. Burns, most commonly in day-to-day life, we see scalds which are caused by hot liquids, garam pani, garam chai. Most common in hospital practice are the flame burns. To study these flame burns, pathophysiological changes like hypoxia, hypovolemia, sepsis, severity assessment by percentage of burns and depth of burns, and management of burns, pre-hospital and the hospital management. In the hospital, first we'll focus on saving the life and then the definitive care. A person who is burning, the various pathophysiological events, hypoxia because of swelling of the airway, upper airway swelling more common with flame burns, lower airway swelling more common with steam burns. Inhalation of black soot particles, carbon particles into the alveoli, chemical alveolitis, alveolar edema causing hypoxia. Toxins in fire, most commonly carbon monoxide, second most commonly hydrogen cyanide. Carbon monoxide has more than 200 times affinity to bind with hemoglobin as compared to oxygen. So oxyhemoglobin will be replaced by carboxyhemoglobin. Cells will not be getting oxygen. Aerobic respiration will not occur. Anaerobic respiration, lactic pyruvic acids, metabolic acidosis in burn patients. A scar, which is seen in deep burns, if it forms over the chest wall, it can interfere with rib movements, so can lead to hypoxia, which will require a scarotomy. To see the hypovolemic changes in a burn patient because of intense inflammation, there will be vasodilation, endothelial gap junctions will become wide, and there will be leakage of intravascular volume and heat into the extravascular space. The most crucial period is the first 24 to 36 hours. Sepsis. The skin is acting as a natural defense barrier and does not allow the external microorganisms to invade inside a body. But in burn patient, when the skin is burnt, then the external microorganisms can easily invade inside the body and lead to severe infections. Most common source of infection in a burn patient is the burnt wound itself. Most common infection in burn patient is by Pseudomonas, second most common by the Staph aureus. If we have to assess the damage in burns, we can calculate the percentage and depth. Percentage of burns, most commonly we use Wallace rule of 9, that is TBSA, total body surface area burn in percentage. Head and neck 9%, front of chest 9, back of chest 9, front of abdomen 9, back of abdomen 9, one complete upper limb 9, front of one lower limb 9, back of one lower limb 9. If we calculate this, this is 99%, 1% is for the perineum. However, in case of children, the head and neck bear larger surface area as compared to adult. At 1 year of age, head and neck burn is 18%. Then we reduce 1% every year. So at 10 years of age, head and neck burn becomes 9% equal to that of an adult. We can use Lund and Browder charts as well in children. There is another palm rule used in patchy distribution of burn, where we take a piece of paper according to the size of the patient's hand. Hand is palm and the fingers. And here does not mean the upper limb, and is just the palm and the fingers, and this is taken as 1%. To assess the depth of burns depends on temperature of the source and duration of contact. Higher the temperature of source, more the duration of contact, more will be the depth or degree of burns. We can classify this degree of burns into first degree, second degree, and third degree. According to ATLS, there is the fourth degree. Only epidermis first degree, dermis second degree, subcutaneous fat muscle bone third degree. According to ATLS, subcutaneous fat third degree, muscle bone fourth degree. First degree burns, they are just like sunburns or abrasions. They are not even included in calculating the percentage of burns. No treatment is required for first degree burns, just exposure. Second degree can be classified as second degree superficial and second degree deep. Second degree superficial means superficial dermis involved. Second degree deep means deep dermis is burnt. Second degree burns, we find blisters quite commonly, and blisters should not be broken because they are acting as sterile dressing which prevent any external contamination inside. Second degree deep burns are generally red, blotchy and painful. The nerve endings are in the deep dermis, so first degree and second degree superficial will be painful, but second degree deep, third, fourth degree will be painless. Third, fourth degree burns, because epidermis dermis is completely dead, it may be white or black leathery in appearance, it will be painless, and because the skin is dead, so we have to remove the dead skin debridement and do a skin grafting. While for second degree burns where epidermis is gone, chances of invasion by the microorganisms is more, so we should put some dressing to cover those second degree burns. Most commonly we use silver sulfur diazine 1%. Management, pre-hospital management, ensure the rescuer safety first. Stop, drop, cool, stop the burning process, drop the person on the ground with the burning surface up, and cooling of the burn wound should be done with running water at room temperature. Ice should not be used because it can cause hypothermia. Then transfer the patient to the hospital, where in the hospital the first duty of the doctor is to save the life, A, B, C, D, E, and then the definitive treatment once the life is saved. A. Early endotracheal intubation is preferred in suspected airway burns. Breathing if respiratory muscles are paralyzed, put the patient on ventilator. Cease circulation. Initial fluid of choice for basic resuscitation will be the isotonic crystalloids like ringer lactate. Very close to ringer lactate is Hartmann solution. If both are not available, we can give normal saline. Colloid should be avoided in the first 12 hours. How to calculate the amount of fluid to be given? Parkland formula says 4 into percentage burns into weight in kgs. This gives us X ml of ringer lactate to be given in first 24 hours. According to ATLS, it is 2 into percentage into weight in kgs. However, in children up to 14 years, it is 3 into percentage into weight in kgs. And in electrical burns, it is 4 into percentage into weight in kgs. In electrical burns, the fluid requirement will be more because electrical current causes muscle damage, rhabdomyolysis, myoglobin comes in the pipeline, which can block the filter kidneys. So aggressive fluid has to be given to avoid choking of the kidneys to avoid acute renal failure. Whatever fluid calculation is coming, that X ml of ringer lactate is given in 24 hours. Whatever formula we use, half of this fluid has to be given in the first 8 hours and remaining half has to be given in next 16 hours. If you are giving sufficient amount of fluid, sufficient pressure is there in the pipeline, sufficient fluid is going to the kidneys, the urine output will be adequate. But if the urine output is less, that means sufficient pressure is not there, sufficient fluid is not there in the pipeline, so increase the amount of fluid infusion. If the urine output is more, decrease the amount of fluid infusion. That is how we are able to generate pressure in the pipeline and supply oxygen to the vital organs A, B, C. Life is saved. Now the definitive treatment for burn wound. First degree nothing, second degree dressing, we can use paraffin gauze, silver sulfur diazine 1% most commonly used. We can use mupirocin, mefenide acetate is painful, causes metabolic acidosis. Serum nitrate solutions can be used, collagen sheets can be used, fish skin can be used. Third, fourth degree burns, dead skin debridement and skin grafting. Skin graft, auto, iso, allo, xeno. Auto, same person, iso, identical twins, allo, same species, xeno, different species. For skin grafting, we use a Humvee's knife and a wolf's blade. We can also use a dermatome. Now, through this Humvee's knife, we can either take a thin slice or a thick slice. Thin slice is most commonly, that is partial thickness skin graft or a split skin graft or a Thiersch graft. Here we take epidermis and superficial dermis only. While in a full thickness skin graft or a wolf graft, we take full thickness of the skin, that is epidermis and dermis, completely. Most commonly, partial thickness skin grafts, split skin grafts are taken from the thigh, the anteromedial and the anterolateral aspect. After taking the graft, the donor site is covered with bandage and a new skin comes in 14 days there. Then this split skin graft is put at the recipient site. Before we put it, we can take the help of measure and we can create multiple holes in this partial thickness skin graft, which will make the skin graft to expand, so a smaller graft can cover large area. Plus, these holes will allow the granulation tissue to come up nicely and will help in better fixation of these partial thickness skin grafts. But these partial thickness or split skin graft, they contract more, so cosmetic outcome is not so good. While full thickness skin grafts, which are most often taken from the post-auricular region or the supraclavicular region, like in ANT myringoplasty, we take the post-auricular full thickness graft to reconstruct the tympanic membrane. The donor site should be covered with suturing. Full thickness graft cannot be expanded, so they can cover only a small area, but the graft contraction is less, so cosmetic outcome is good. For face, we prefer using full thickness skin graft. Composite grafts can be used where not only the skin but underlying fat or cartilage can be used, like when we have to put it over the end of the nose or the eyebrow. When we are doing the skin grafting, how the skin graft survives? First 48 hours, there is plasma imbibition of the nutrients from the underlying surface. Third day, there is inosculation where bridges develop. And by fifth day, the graft settle at the recipient site. Neovascularization. Skin grafting should not be done if there is any infection at the recipient site, especially by beta hemolytic streptococci, because it can eat up the skin graft. We cannot put the skin graft on bare bone, cartilage or tendon. Other surgeries which can be done in burn patients, like if there is a deep burn forming an eschar which is acting as a tourniquet, then we have to release this eschar. We have to cut the skin, escharotomy. If electrical burn is there which has caused significant muscle injury, it can lead to compartment syndrome, just like crush injuries what we see in orthopedics. And in these cases, we have to do urgent fasciotomy. Nutrition, enteral is preferred and it should be started within 6 hours unless contraindicated. No role of prophylactic antibiotics. Physiotherapy should be started on day 1 to prevent post-burn contractures. However, if skin grafting has been done, it takes 5 days for the graft to settle at the recipient site. So in skin grafting, physiotherapy should be recommended after 5 days. And this should be done under nice supervision so that contractures do not develop. Most common cause of immediate death in burn is hypoxia, suffocation, asphyxia, early death, hypovolemia, late death, sepsis. Electrical burns, they can cause muscle damage, rhabdomyolysis, myoglobinuria, acute renal failure can occur. Electrical current can interfere with the pacing of the heart or cause direct cardiac damage. So ECG is mandatory. That means we have to be aggressive in the fluid management. ECG has to be done, and if compartment syndrome is developing, we have to do urgent fasciotomy. Chemical burns, whether acid, alkali are more dangerous. In chemical burn treatment, we have to rinse that area nicely with running water at room temperature for a long duration, 20 to 30 minutes. Neutralizing agent should not be used in chemical burns. Like if it is an acid burn, don't put alkali. If it is a powder chemical burn, first remove the powder with a brush. Cold injuries like frostbite and trench foot non-immersion injuries. Frostbite is a dry cold story. Trench foot or non-freezing injury is a wet cold story. Both are seen almost at freezing temperatures. In frostbite, there is complete microvascular occlusion, but in trench foot, which is common in wet conditions like rainy weather or maybe sailors, fishermen, there is alternating spasm and dilatation of the arterioles. So the risk of gangrene would be high in frostbite where there is complete occlusion. risk of gangrene will be less in trench foot. The frostbite can be classified as per the degree of burns: first degree epidermis, second degree dermis, third degree subcutaneous fat muscle bone. In frostbite, we may find it as white, hard, numb type, while in trench foot, signs of inflammation, rubor tumor, redness, pain, raised temperature, ecchymosis, ulcers, blisters can be seen. In the treatment for cold injuries, we should do rewarming at 40 or 42 degrees centigrade in warm water bath for a longer period, 20 to 30 minutes. One medicine which can help is aspirin. It helps in thinning of the blood, supplying oxygen to the target area. And surgery, especially in frostbite, should not be done early, because in cold injuries, it takes time for denaturation of proteins. So it takes time for a clear line of demarcation to develop between the viable non-viable part. Until that time, amputations should not be done. Surgery can be delayed for weeks or months in frostbite, unless a clear line of demarcation develop between the viable non-viable. Thank you very much for your patience, beta. May God bless you like anything. May you keep on studying as hard as possible. You are going to rock. Nobody on this earth has the power to stop you. You are going to achieve. You are going to bring those happy tears in your parents' eyes.